Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn Liz Powell, Medical Editor at MIMS Learning. Today I'm delighted to welcome Dr Steve Brinksman to the podcast. Dr Brinksman was a GP in Birmingham for 30 years, working with people who have problems with alcohol and other drug use. He's also the Medical Director of Cranston, a charity providing substance misuse services. Today I will be speaking to him about supporting people who may be misusing alcohol. Welcome to the podcast, Steve.
Good afternoon, Dawn. It's nice to be here.
Okay, let's start off by defining what we mean by alcohol misuse. I used to work in a newsagent many years ago and I could easily pick out the alcoholics. They were the ones who sort of smelt of alcohol and they were buying a super strong cider in the morning. But I mean, that's like the stereotype of what you would think an alcoholic is. Alcohol misuse can be actually much more subtle than that, can't it?
Oh, very much so. We stereotype because it makes us feel better about our own behaviour. So if you sort of see people who are, as you say, buying alcohol in the early hours of the morning and smelling of alcohol and are dishevelled, you're not like that. So you actually feel that, oh, well, maybe I'm okay. And yet you could still be drinking at a level that is damaging to your health. Alcohol use disorder is very, very prevalent. And the harm occurs long before people have physical dependence, which is why we tend not to use the term alcoholic very often these days.
Sort of a top level, what do you think the prevalence is of people who might have some sort of issue with alcohol in the UK?
If we're talking about people who have severe dependence, that's probably about 0.5% of the population. But if we're talking about people who are drinking at a level that might cause them harm or even significant harm, then we're probably closer to 15 to 20% of the population.
In terms of more thinking about in a broader aspect of alcohol misuse, do you think British culture might encourage alcohol misuse? I mean, certainly when I was at university, getting drunk was something you sort of encouraged and sort of celebrated. A good night out was when you got really drunk.
Yeah, a good night out was when you couldn't remember it. I had those days as well when I was a medical student, but it's a key part of culture. We use it to celebrate occasions, we use it to commiserate, we use it to make friends, we use it to go out. And yet, actually, social attitudes are changing a little bit. It wasn't that long ago that people would drink drive. Smoking has changed, even passive smoking has been taken into account. And if we look across the channel at Europe, particularly in France, where they had much higher rates of liver cirrhosis than us in the 70s, their levels are much lower than ours. And that's due to a massive change in culture in France and people drinking less. So, yes, it is a big part of society. There are lots of things that encourage us to drink heavily, but things do change. And I think, interestingly, the younger generation, particularly the Gen Z generation, seem to be drinking significantly less than older ones, although to some extent they are compensating by using other drugs.
I suppose it's just something to be aware of, that the British people are quite awkward as a group, and alcohol is quite an easy way to be less awkward.
It's a well-known fact that some countries, they say British people would never ever get kissed if they didn't have alcohol. So it's a social lubricant, but unfortunately it's also a lot more than that.
So in terms of what the alcohol can actually do to the body, because I think you were sort of saying before, it can start to have an effect before you kind of even realise it's having an effect. Because obviously the average person on the street knows that alcohol misuse will damage your liver, but what else can it do? And when will these effects start to be seen?
Alcohol's been associated with well over 60 different illnesses as a contributing factor. One of the things that people often don't realise is there are more deaths attributable to alcohol from cardiovascular disease than there are from liver disease. And the attributable factor in cardiac disease from alcohol is around about 50%. So about half of all cardiovascular diseases are related to alcohol consumption. It puts people's blood pressure up. It's also associated with many cancers, particularly breast, esophagus, bowel. When the harm shows, that's the problem, is everybody varies. It's hard to know whether the level you're drinking at is causing you individual harm, because many of these things will only show later on. And that's why the CMO has set guidance suggesting we don't drink more than 14 units a week and not all in one go. But essentially, the only way to have no increased risk from alcohol-related diseases is to have no alcohol. I'm not suggesting that that's what everybody should do. if you drink within the guidance, you definitely will be at low risk. However, most of the harms from alcohol are dose related, most of the physical harms. So, if you're drinking 50 or 60 units a week, then you reduce your harm by cutting down even to 40 units a week. So I think what we need to try and get across to people is that everybody thinks, oh, if I go to the doctor and say I'm drinking too much, I'll be told I have to stop drinking. And actually, what we need to do is everybody to just drink a bit less. And that would significantly reduce the burden on the NHS and particularly on primary and secondary care.
Okay, so just a couple of questions there then. When you're talking about units, going back to my student days, I remember this one as well. It wasn't so much the students were out getting drunk, it's that they were binge drinking. Like you're talking about dose dependent, because it's not just so much how much you've drunk in the week, it's how much you've drunk at one particular time, because that's a concern as well, isn't it?
Yes, if you are binging, you obviously at more risk of acute harm during that. I mean, there's association with accidents, there's association with unprotected sex, there's association with things like drowning and so on, and acute alcohol poisoning. But from a clinician's point of view, looking at binge drinking, we're actually just talking 8 units or more for a man and 6 units or more for a woman. So levels that you wouldn't necessarily say I've had a binge if you're a student, but those are the sort of levels that we think of as being significant in terms of the damage that they cause. But having alcohol-free days is definitely a better thing for you than just chronically using, even if the total amount of units consumed is the same.
Sometimes a person will go to the doctor and they'll be concerned, oh, they're going to make me stop. And, they might well just reduce it instead. But if somebody has got a very serious issue with alcohol, can they reduce it? Because they'll either drink or they won't drink, but they can't do it in between.
Alcohol dependent, so you're physically dependent, then obviously we wouldn't encourage people to stop suddenly because they do run the risk of alcohol withdrawals, and which can be quite significant and carry a significant mortality. However, looking to reduce your alcohol can be done, and there are, within Cranston, we will work with people around reducing that who don't want to become abstinent, around techniques to reduce your alcohol. And that's been well established that controlled drinking will work for some people. If people are dependent, then they need to be abstinent. If people have got very severe physical illnesses related to alcohol, then they need to be abstinent. And that's what we would encourage people towards. And other people may want to stop drinking because they're just fed up of waking up feeling awful in the morning, missing work, or just not remembering what happened the night before. And again, they should, if they want to move towards abstinence, that's fine. But when people are not ready for that, we can still reduce harm by teaching them techniques to reduce the amount of alcohol that they consume. And that can be as simple as swapping to a drink with slightly less alcohol in it. So if you're drinking 5% beer and you switch to a 4% beer, you've reduced your alcohol by 20%, even if you drink the same number of pints or cans. So there are techniques, getting people to alternate between low alcohol and normal alcohol drinks, again, is a way of cutting things down. Avoiding drinking in rounds, because once a round starts, it's got to be completed. So there are lots of things that people perhaps have not thought about, and also thinking about cues. If you go to the gym and then you meet your friends in the pub, occasionally try and meet somewhere else, the cafe, or go to the cinema. Just change what you do to try and make those changes. But it's no different to any other behavioural change that as GPs we're trying to get people to do, whether that's increase their exercise, whether that's lose weight. It needs lots of work and lots of support, but people can achieve it.
I mean, obviously there is a relationship between alcohol misuse and mental health. Seems it's like kind of bi-directional. Somebody who's reporting to you that they're concerned about how much they're drinking, presumably a GP, that should be a sign that this person might have sort of ongoing mental health issues.
Yes, it becomes very much chicken and egg in terms of alcohol causes depression and anxiety. However, people often use alcohol to try and deal with depression and anxiety as sort of maladaptive coping mechanism. If that's gone on for quite a few years, it can take quite a lot of effort to unpick before you're able to work out which is which. There are studies showing that people who can significantly reduce their alcohol consumption, their depression will improve. So it's definitely, as long as the person isn't physically dependent on alcohol, I think trying to have a period without significant levels of alcohol might well be all is needed, rather than put them on, what could be several years worth of antidepressants. It's one of the things that needs to be considered. And also, people with very significant mental health conditions often use alcohol and often cigarettes and other drugs as well as part of their attempt to try and deal with the reality of their existence.
How would somebody with an alcohol misuse typically present? I mean, are they more likely to be reporting it to themselves, or is this something a family member might actually raise?
Very varied. I mean, some people will come in and they'll say, I'm worried about the amount that I'm drinking. Obviously, sometimes it will be a partner will raise that. Quite often, it'll be if the GP suspects, if they're presenting with a condition that might relate to alcohol consumption. So they, as we just mentioned, depression, but also raised blood pressure, gastroesophageal reflux. Those are things that would make me think I probably should ask this person about their alcohol. And if I was going to ask them, then you need to ask using a proper validated screening tool. I think the trouble with saying to people, how many units do you drink, is everybody's immediately on the back foot and playing a defensive shot. And they're sort of thinking, what do I say that seems reasonable? It's not a very accurate way of assessing people's alcohol consumption. So that's why we would always recommend using one of the validated screening tools. The one that I use the most is called AUDIT, the Alcohol Use Disorders Identification Test. It was developed by the World Health Organization and it was tested in many, many countries. And it's 10 questions that ask people about how often they consume alcohol and when and what their effects of that might be. And it can actually be administered by the clinician, but it can also be given out to patients to fill in themselves. It's got a very high sensitivity and specificity, both well over 90%. So it's very good at spotting people who do have a problem with their alcohol use. Clinicians actually quite good at spotting people. If a clinician thinks you've got alcohol problems, they're normally right, but there's an awful lot of people who've got alcohol problems that the clinician doesn't suspect, which is why the audit is better. There's also a shortened version for busy people like GPs called Audit C, which is 3 questions from the full audit. And if that's positive, then the other 7 questions should be asked to get to the full score. But what the audit does is it actually gives a score, and the scores are in bands. So low risk, higher risk, increasing risk, and possible dependence, which would correlate roughly with our guidance of hazardous and harmful and dependent drinking.
What if that person just doesn't want to engage with it, talking about the alcohol? What should the GP do then?
If we're sure that the person has capacity, then they're entitled to make the decision not to do anything about it. However, I would make a note that it's been done and I would review it in the future. If someone told me they weren't interested in stopping smoking, I wouldn't never ask them again the next time they could, because at some point they may say, oh yes, I am. The same with, say, childhood vaccinations. You don't say to, if a parent says, I don't want my kids to have immunizations, you don't just say, oh, well, that's it, we'll never bother. It's something we keep going back to because we know it's in their interest. And they're allowed to make the same decision again, but we should be revisiting it and where we know that it's likely to be an issue.
Is it? Because I know, like with obesity, that's always a tricky area as well. So you've got someone who's repeatedly coming in for this, like the other, and you might think, oh, that's related to the weight, and you've got to be careful about raising that. Is that something might be an opportunity to raise the issue again?
If we think it's related to something, whether it's obesity or whether it's alcohol, I think we have a duty to raise it with the person. You're still empathetic towards their situation and you're not using it to be critical, but you need to point out that there's a relationship. If someone came in with a recurrent episodes of chest infection and they were a smoker, there's no GP who wouldn't mention the fact that being a smoker is likely to be contributing. But it's the way in which you mention it. And also by saying there is help available and there are things that we can do to improve it, I think that's a key as well.
Okay, and just in terms of safeguarding, so say if you've got someone you think they're severely drinking, whether or not they want to engage it, maybe they're a parent or they're looking after somebody, or maybe they're in a job with their level of responsibility. What does the GP then? What are their legal obligations in terms of safeguarding, ensuring that patient is not going harming somebody with their drinking.
It's the same as with any other safeguarding issue. If you think that there is somebody who is potentially at risk, then you need to follow your local safeguarding procedures. If it's a colleague that you think is drinking and may have a problem, I would encourage them to seek help. I would, if possible, advise them to take some time from work. And if they're reluctant to do so and you do feel there is a significant risk to patients, then I think it's time to speak to your defence body and explain the situation and get their support, because you may have to then take further action and refer that person on. But I would try very much to get the person to seek some help. I mean, many of the GP and hospital doctor support schemes are dealing with addiction problems. Unfortunately, we are in a profession where that is a common problem and affects us more than the general public on the whole. And may also be a reason why doctors are slightly more uncomfortable asking people how much they drink, because there's a little bit of please do as I say, not as I do. We then feel uncomfortable about ourselves by asking those questions. So sometimes it's easier just to avoid them.
Say you do have somebody who is engaged and does want to do something about reducing their alcohol. What are the next steps? Because I think, you sort of said, yes, you can give them some techniques for reducing their alcohol intake, but what else would you be doing?
Well, say the first thing is user-validated screening tool. I've already mentioned Audit C and Audit, and that will give you an idea of where the level of drinking is. If they're in the increasing risk category, their audit score is between 8 and 15, then what we call brief interventions, which is a little talk going over the things I did. Do you understand how to count units? Have you ever used a drink diary? Have you considered using a lower strength drink and alternating and so on? And that and a leaflet just helping to remind them of that has been shown to be very effective. In terms of numbers needed to treat, brief interventions have a number needed to treat of 8, which is better than smoking cessation. It's a lot better than the number needed to treat for primary prophylaxis with statins, for instance. And it doesn't involve any medication. It's a 5 to 10 minute conversation and a leaflet. Where people are in the harmful drinking category, so their audit score will be between sort of 15 and 19, then they're likely to need some psychosocial interventions, some sort of maybe some counselling and stuff as well, because, as I say, it may be relating to previous trauma or other problems. Now, I would therefore encourage people to have a referral to the local drug or alcohol treatment centre or to look at some other form of therapy. But again, you can still give them advice that might help them to cut down. Audit doesn't give a diagnosis of dependence, but it suggests it. So people scoring 20 plus on audit need an assessment for dependence. So they need a physical exam. Are there any signs associated with liver disease, cardiovascular signs? And then they are going to need a referral, and hopefully they would accept that, alongside perhaps screening for cirrhosis and doing liver function tests, and which is something that obviously we can arrange in general practice. But drug and alcohol treatment services should be dealing with those people at that end. But the point I always like to make is that everybody who becomes a dependent drinker was once a harmful drinker, and before that an increasing risk drinker, and they will have had multiple interactions in the primary care sphere that actually something could have been done at that point. We can't change everybody, but I just think that by spending 5-10 minutes of discussion early on and giving people a leaflet, we can stop some people moving through into the dependent drinker role. Then I think it's a very useful part of our time. And also brief interventions can be delivered by HCAs, by nursing staff. It's not a doctor only role. But if people want help, then the help is available. And also, if you refer somebody to the drug and alcohol treatment team, then you've got a record that you've done that. And when they come back, you can check that they went, you can see if they're having any problems and follow them up. If you sort of say, oh, well, here's a leaflet, here's a number, give them a ring and refer yourself, then actually the person may have lost their motivation by then. You don't know whether they did it or not. Most drug and alcohol treatment agencies will actually appreciate the referral because we get all the extra information as well around other medications and so on.
We're just talking about other medications because we've got a module on MIMS Learning about smoking cessation in people with severe mental illness. One of the things that talks about is that you need to modify, I think, the antipsychotics depending on not whether the person is continuing to smoke. Is that the same regardless of whether they've engaged in services or if they're doing something about the drinking? If you think they are drinking to a significant level, how much the dose of what you're going to give them of say if they've also got diabetes?
Basically, in terms of medication for people who have got alcohol use disorders, we're normally, if we're doing a medically assisted withdrawal, we'll be using a benzodiazepine. Normally chlordiazepam oxide, but sometimes diazepam. So obviously any drugs that would interfere with that would need to be known about. And then post detoxification, there are a number of medications, particularly acamprosate and naltrexone, which can be used, which have a beneficial effect in reducing craving and reducing relapse. Now, naltrexone is an opioid antagonist. So if the person, for instance, is on opioid painkillers, we can't use that because it will stop them working. So that's why it can be quite important to know what medication people are on. I should have made the point earlier, but what's really, really important is anybody who's drinking harmful and higher level should be taking oral thiamine. B vitamin is very poorly absorbed in people who are drinking large amounts of alcohol. And if people go into withdrawal, then they run the risk of acute thiamine deficiency, known as Wernicke's encephalopathy. That causes quite significant brain damage and is a significant factor in people ending up with alcohol-related dementias and alcohol-related brain disease, which are very expensive conditions to treat and look after people in the community. So thiamine, it costs pence, and people who are drinking at higher levels really ought to be being given it at the moment that's assessed. And we will do that through the Drug and Alcohol Service. But I think if a GP can start it sooner, it can be an absolute lifesaver and preserve people's brain function.
In your sort of experience of supporting people with alcohol misuse, what do you think has been the biggest misconception, either from patients or from healthcare professionals, about supporting alcohol dependence or sort of trying to help people with alcohol dependence?
A lot of people feel that alcohol dependence is refractory to treatment, that there's nothing you can really do. I hear people saying, well, until you hit rock bottom, you won't get any better. And that's actually not true at all. There was a large trial done many, many years in the UK alcohol treatment trial that showed that actually about 40% of people who were dependent stopped drinking following treatment. And of the other 60%, over half of those significantly reduced their drinking. We're in the harm reduction business. Anything we can do to stop people developing diseases, to stop people having to go to hospital, that's worthwhile. If you've got treatment that improves 60 to 70% of people, then that's a very significant number. I think one of the problems is it's often a relapsing illness, and we often only see people when they're bad. So I think sometimes as a GP, it seems like the person may not be making any progress, but we shouldn't be pessimistic about people who we've identified as having an alcohol use disorder. With the right treatment and encouragement, many, many people will significantly improve.
Finally, what are your take-home messages for GPs?
Okay. Always use a validated screening tool. Don't just ask how many units a week they drink, and consider using that every time you were going to initiate an antidepressant, an antihypertensive, a PPI, any condition that might relate to that, as well as people who express a fact that they're concerned about their own drinking. If people are regularly consuming large amounts of alcohol and they're at a harmful or higher level of drinking, please prescribe them thiamine. 50 milligrams QDS or 100 milligrams TDS, it's poorly absorbed in people who are drinking heavily, so it needs to be given multiple times a day, with the hope that at least several of those doses will get taken. And if the person is willing, refer them to treatment services so that you've got a record that that's happened and you can follow them up. That's far, far better than just saying signposting.
Okay, well, thank you so much for speaking to me today, and thank you to our listeners for joining us. Don't forget, you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. I've been Dawn Liz Powell, speaking to Dr Steve Brinksman about supporting people with alcohol misuse, and this episode was produced by Jude Owen. Look out for our next episode, where the MIMS Learning editorial team will bring you more highlights from the comprehensive CPD modules on our website.